So to start with, I just wanted to remind you about the different cell types that make up the brain. We're always focused on neurons. So neurons are the cells that are actually generating electrical activity that are communicating inside the brain. But they don't do this job on their own. The neuroglia are actually the much more abundant cell type in the brain. And there's a lot of different type of glia. So neuroglia refer to cells that are not neurons that are also part of the nervous system. And you'll remember that we have the central nervous system, which consists of the brain and the spinal cord, and the peripheral nervous system, which as soon as the nerves leave the spinal column, they're considered part of the peripheral nervous system. So nerves that come out of your spine and go to your muscles, or sensory nerves that come from your skin or your other sensory organs and go into the spinal cord, all of those nerves are part of the peripheral nervous system. So in the central nervous system, in addition to neurons, and there's a lot of different types of neurons, we have all of these support cells. So we have ependymal cells. Who knows what the ependymal cells are or where they are found? Yes, so the specialized ones called choroid plexus actually secrete CSF. Cerebral spinal fluid. The ependymal cells are the cells that line the ventricles. So in the middle of your brain, you have the lateral ventricles, and those wrap down into the cerebral aqueduct. They go into the fourth ventricle, and then that leads to the spinal cord. And so you have CSF that circulates all through the brain and the spinal column. And that CSF is made by specialized ependymal cells that make up the choroid plexus within the lateral ventricles. But these ependymal cells line the ventricles all throughout the brain. And they provide a lot of support. So they have these long little fingers, and they're kind of sensing what's going on. They're providing nutrients, to providing structural support to the rest of the cells in the CNS. Similarly, you have astrocytes. So astrocytes are your other big support cells. You can kind of think of them as similar to fibroblasts. They provide a lot of nutrients. So neurons need glucose. They're actually not even insulin dependent. They just need a steady supply of glucose. Astrocytes can produce that glucose for them in times of starvation. So astrocytes help to feed the neurons. Astrocytes help to produce growth factors. They help to produce the extracellular matrix of the brain. And they're activated during injury, and they help with the repair process within the brain. So they're really important cells. Who knows the main function of the oligodendrocytes? Yes. Yes, so the oligodendrocytes actually produce myelin, and what does myelin do? Yes, so it allows for increased connectivity of the nerve signal. In other words, it's like the insulation on wire. So your neurons communicate by sending electric signals down their long axons, and then they pass that signal on to the next cell. Well, along that axon, you're transmitting an electrochemical current. And what myelin does is it helps speed up the transmission of that current. So it makes it go faster, it makes it go more efficient. And we know this is really important because demyelinating diseases like multiple sclerosis have a lot of negative neurologic effects for people. So the oligodendrocytes produce myelin. And then the microglia, these are akin to macrophages. They're actually derived from monocytes, just like macrophages are derived from monocytes. Those monocytes travel across the blood-brain barrier into the brain, and they provide immune support to the brain. The brain is immunologically privileged. That means it's not exposed to the immune system the way the rest of the body is because of the blood-brain barrier. So immune cells have a much harder time getting into the brain. Not all cytokines can get into the brain, although some can. And it's because the blood-brain barrier is really just an extra layer of tight junctions between the endothelial cells of the blood vessels in the brain. So it's between the lumen of all of those blood vessels and capillaries, there's an extra layer of protection. Those endothelial cells are extra tight to protect the brain from systemic inflammation, from the immune system, from pathogens that might get into the blood. So it's a really discrete network within the brain. And these microglia that do get into the brain, they do a lot of the jobs of macrophages. So when they're triggered, they can actually produce cytokines, they can recruit inflammatory cells if needed, and they can phagocytize pathogens or necrotic debris. And then in the peripheral nervous system, we have Schwann cells. Schwann cells are similar to oligodendrocytes. They also produce myelin. They live in the peripheral nervous system, so they only myelinate the axons of your peripheral motor and sensory nerves. The satellite cells, these are similar to astrocytes. And they're really the support cells of neurons that live outside of the central nervous system. So there are most neural cell bodies are part of the central nervous system, but you have these sympathetic ganglia and dorsal root ganglia that are actually neurons that live right next to the vertebral column, but outside of the central nervous system. And so they need some of the same support, and the satellite cells are their support network. So here's an artistic rendition of what the brain is like. So all of these cells are living in harmony. Here's your neuron. This yellow cell is the neuron. And you can see the neuron actually has a lot of connections with astrocytes. So astrocytes are feeding them growth factors. They're helping to give nutritional support, metabolic support. They help detoxify within the CNS if there's too much radical oxygen species being made. Here's the microglia hanging out, waiting in case there's something, some kind of PAMPs or DAMPs around. Your ependymal cells also are reaching in and providing support there. And notice that here is the axon of the neuron, and it's coated with myelin to allow that conduction, that electric conduction, to go faster. Quick review about the types of synapses in the nervous system. So by far the most common, and what's going on in your brain, are neurons synapsing with other neurons. And there are billions of synaptic connections within your brain. It's really quite amazing. So remember that what happens is you have all of these dendrites, and the dendrites are the receiving end of the neurons. So they're receiving signals from all other neurons. And they take all of those signals and make a binary decision, go, no, go. So if there's enough electrical excitability, it'll generate an action potential, and now this neuron is communicating with the next neuron. If there's not, no action potential. So all of this communication comes down to action potential or no action potential. And that's true for all of the different types of neurons. The difference between the different types of synapses is what happens on the other end. So for this neuron, it's communicating with the next neuron. It's basically giving some signals, which that neuron will summate with all the other connections it's getting from other neurons and make a decision about whether to send that connection on. So thousands of these neurons interacting are what's going on in your brain all the time when you're listening to me, when you're forming connections with prior learning, when you're recalling what you had for dinner last night and why your tummy's hurting a little bit right now. All of those are going on simultaneously in your brain amongst all of your neurons, and that produces all of our perceptions. Motor neurons are neurons that synapse onto muscles instead of another neuron. So when they send an action potential, they actually release acetylcholine. That acetylcholine binds to the skeletal muscle and triggers the opening of calcium channels, which triggers muscle contraction. So motor neurons generate muscle contraction through the neuromuscular junction. And then the third type that we've seen are these neuroglandular synapses. So where is an example of a neuroglandular synapse? Pituitary, yes. So you have in your hypothalamus, you have neurons that are getting communication from a lot of other neurons, from visual, from sensory, about your environment. They're getting feedback, neuroendocrine feedback. And they decide, is that enough information to send a signal down to the glands? And what they do is they synapse onto these glands, and they tell the gland to synthesize and secrete whatever endocrine hormone they are in control of. So that's the third type. But again, by far the most common are the neural connections. So what's going on at the synapse? Here comes the action potential. It's coming down the axon of the neuron. And then you have all of these little synaptic boutons, or little synaptic terminals at the end here. So here's one synaptic terminal. When the nerve impulse comes down, what's carrying the nerve impulse? What chemical? Do you guys remember? Yeah? What's that? No, not acetylcholine. Acetylcholine is one neurotransmitter. But what is actually generating this nerve impulse? It's sodium. Yep. So remember, you have these voltage-gated sodium channels that open up all along, and it allows sodium to come in. Sodium is positively charged. That opens the next sodium channel. Some more sodium comes in, and so you just get this influx of positive charge all the way down the axon. When it gets to the terminal, to the synapse, that sodium generates a positive electrical charge within that synaptic terminal, which opens these voltage-gated calcium channels. So all along here have been the voltage-gated sodium channels. Now at the end, we have voltage-gated calcium channels. Usually, intracellular calcium is very low, so now you have this sudden influx of intracellular calcium. That intracellular calcium is a signaling molecule, and it helps the fusion of these preformed neurotransmitter vesicles. So there's vesicles sitting here that are full of neurotransmitter. When calcium comes in, it causes those to fuse with the membrane of the synaptic terminal. As they fuse, it releases the neurotransmitter that's inside of it into the synaptic cleft, into that space between the presynaptic neuron and the postsynaptic neuron. So the presynaptic neuron is the one that just carried that nerve impulse. The postsynaptic neuron is getting that signal along one of its dendrites. It's receiving that information. So the neurotransmitter gets into the synaptic cleft here. It diffuses across. It's a very narrow space, but it is a space. And it binds to postsynaptic receptors. So these are receptors on the other neuron, the receiving neuron, and when they're bound, it opens a sodium channel. So the receptor binds, the neurotransmitter binds here, opens a sodium channel. So now that receiving neuron has one input that said, I have a signal from this cell. So you have an increased sodium here. That doesn't necessarily mean that postsynaptic neuron is going to fire. It's getting hundreds of signals. So it may have 500 synapses, and perhaps it needs about 300 synapses to be positive, so it needs that amount of sodium influx in order to generate the action potential. So an action potential, again, it's a binary switch. It's either it goes or it doesn't go. So you have to reach a threshold. You have to have enough sodium to reach that threshold. If you reach the threshold, the voltage-gated calcium or sodium channels open, and you send that electric signal down the axon to the next cell in line. Any questions? Okay. So let's start with a question. Myasthenia gravis, anybody heard of this disease? So it's an autoimmune disease, and patients actually produce autoantibodies that recognize the acetylcholine receptor, which is found at the neuromuscular junction. There's also acetylcholine receptors in the brain. In myasthenia gravis, the autoantibodies bind to the ones that are at the neuromuscular junction. So first question, this is mostly a review. What type of hypersensitivity reaction is this? I hear people saying B. How many people think B? How many people think C? How many people think D? Yeah, they can go together. So we're producing autoantibodies. Those autoantibodies are binding to in situ antigens. So these are antigens that are part of your own tissue. So this is a type 2. This is B, an antibody-mediated hypersensitivity. And remember that immune complexes bind to antigens that are free-floating in the blood. And then they form a complex, and that whole complex gets deposited in the tissue. Whereas in type 2, the antibody is actually binding to an antigen that's part of the tissue of your body. So in this case, part of the neuromuscular junction. And as you could imagine, that interferes with the synapse. It interferes with what's going on here. So in myasthenia gravis, you have antibodies that are binding to this acetylcholine receptor. So not only do you get all of the downstream effects of antibody-mediated inflammation and tissue destruction, but these antibodies are blocking the binding site for acetylcholine. So your motor neurons are sending the signal to your muscle to contract, and the acetylcholine can't bind, so the muscle isn't receiving that signal. So next question. Again, we're talking about myasthenia gravis, sorry. What symptoms do you expect to see in a patient who has myasthenia gravis? This is a collaborative question, so go ahead and talk with your neighbor. Which of these symptoms do you think you'll see in myasthenia gravis? I think it's useful when thinking about disorders, and I'm going to focus on the central nervous system, but I think it still is useful to have a framework of understanding of the nervous system. The central nervous system is actually just the brain and the spinal cord. So anatomically, it's quite simple. The peripheral nervous system, however, is everything else. And if you see a diagram of the nervous system, you'll see that you could basically recreate a person's whole body just by looking at the nerves, because we have nerves going to every inch of our body. And outside of the central nervous system, those nerves are either carrying sensory information or they're carrying motor information. So motor information is coming from motor neurons in the spinal cord. It's going out to your muscles. Sensory information is coming from all of other areas of your body, every part of your skin, all of your mucous membranes, your eyes, the retina of your eyes, your olfactory epithelium inside your nose. So you have all of these sensory neurons bringing information about the world into the central nervous system. And for this sensory, we can divide it into somatic and visceral. Who can describe that distinction? Does anybody know what that distinction is? Yes. So somatic is going to be skin level, and visceral is going to be deep. That's one way to think of it. The visceral is actually the internal organs, and the somatic is everything else. It really derives from embryogenesis. As the embryos develop, you have these somites along the neural tube that grow out and become all of your muscles and skin. So somatic sensory is coming from mostly the muscles and skin. And these are things like proprioception that allows me to know that right now my arm is above my head. Even if my eyes are closed and I don't see it up there, you have a sensory awareness of where your body is in space and relative to you. So that's all somatic sensory. That's also touch. It's pain. It's cold. Visceral sensory is your internal organs. We have much less awareness of our visceral sensory organs. The reason when you say you have a stomach ache and someone says, "Where does it hurt?" I do this to my kids all the time, and they just basically say, "Here." Because it's really hard to know. You can't pinpoint and say, "Oh, it's my upper ilium is hurting right now." You don't have that type of sensory awareness. Your visceral sensory is much more diffuse. So you may have one sensory neuron that's getting information from a whole long length of the GI tract. We do have some visceral sensory around the spleen. So if your spleen is enlarged, it hurts. And that's because you have visceral sensory in the capsule of the spleen. But again, in general, it's much less discrete than the somatic motors or somatic sensory system. And one really interesting diagnostic tidbit for appendicitis, it'll start as visceral sensory pain. So somebody has appendicitis, they'll say, "Oh, my tummy hurts. Oh, it's getting worse, it's getting worse." And then they'll start to say, it really hurts right here. And you'll get what's called rebound tenderness. If you poke them right here, they will scream and jump off the bed. And it's because instead of visceral sensory, now that inflammation is actually gotten so inflamed, it's starting to get into the motor, into the muscle and the peritoneal lining of the abdominal cavity. So you can now pinpoint the pain. So as soon as you can start to pinpoint the pain, it's bad. Back to the motor. The motor is also divided into visceral and somatic. So somatic motor, that's all of our movements. The neuromuscular junction is our somatic motor system. But we also have a visceral motor system. Again, we have much less control over this. In fact, this is called the autonomic nervous system because we don't have any control over it. And oftentimes we'll call this the voluntary. So you have your voluntary motor. If you decide you want to move your hand forward, you can do it. If you decide you want to dilate your pupils, try really hard. Can you dilate your pupils? You don't have any control over that. That's under the sympathetic division. That's your fight or flight. And the parasympathetic is rest or digest. So those two parts of the autonomic nervous system. focusing in on the brain. The brain, again, lots of different cell types involved there, but the primary cell type that's actually communicating and generating thought, generating motion, perceiving sensation, that's your neurons. And all the others are supporting the neurons. And within the brain, you have millions and millions of neurons that are all interconnected, but yet at the same time, we have discrete regions that have specific functions. So this brilliant neuroscientist a while back named Brodmann, he would just very methodically look at the nerves, look at the cells, their organization in the brain, and just based on that cytoarchitecture, he came up with, I think, 43 different areas of the brain. These are Brodmann's areas. And we still use that as a map of the brain today. And it turns out often many of those anatomically distinct regions map onto functionally distinct regions. For example, we have Broca's area right here. These are Brodmann's areas 44 and 45. Okay, so there's more than 43. So this is a motor speech area. People who have a stroke that affect this Broca's area have a lot of difficulty producing speech. They know what they want to say, but they can't make those sounds. So it's a very discrete function. Everything else can be quite normal. So prefrontal cortex, this is that executive function and attention. So this is the area that in ADHD seems to be less mature. It's not functioning quite as it should. So this is where you have planning, judgment, the ability to inhibit. It's called inhibitory control. If you're focusing right now, all of you are focusing and nobody's getting up out of your seat and wandering around. You may want to, but you have enough control of your prefrontal cortex to inhibit that. Young kids with ADHD don't have that ability, and that really comes from this area here. So the main point of this slide was just to show you that the brain has functionally discrete units. You'll remember that this is the cortex, and we divide it into, we have frontal, we have parietal cortex, occipital cortex, temporal cortex. Do you guys learn all of that in A&P? Okay. Cerebellum, and then in the middle here, here's our pituitary gland, the hypothalamus, that control center. Thalamus is really a sensory relay area. Anybody know what the corpus callosum is? Yeah, it's the connection between the two sides of the brain. So all of the neurons on one side of the brain know what's going on in the other side of the brain. These are white matter tracts. White matter refers to myelinated tissue. So these are axons that are going across the two hemispheres of the brain. And they used to do corpus callotomies in patients with severe epilepsy. They would actually just sever the corpus callosum. And that would, if a seizure starts in one half of the brain, it wouldn't spread to the other half of the brain. So it was pretty effective for preventing the spread in grand mal seizures. But turns out they had a lot of really interesting neurologic deficits. You can't just cut communication between the two halves of the brain. And that made it, if you're interested in this, Oliver Sacks writes really great books about his neurologic patients and what we've learned about the brain based on a variety of symptoms and tests that they run. I could go on about it all day, but I'm going to keep moving so that we get into the actual pathology. Which reminds me to look at my watch. Do you want a 2-minute break? Okay. We'll take 2 minutes. Start that. The fluid is coming from the vessels. It's coming from the blood. So it's just like what we've learned about in inflammation throughout the rest of the body. If you have leaky blood vessels, if the endothelial cells become less tight, then you'll get fluid into that space around it. And I saw a question over here. Nope. Okay. So the primary cause of this would be inflammation. Causing the vessels to allow the fluid component of blood to leak out. Plasma would leak out. What about cytotoxic? From the ependymal cells? No, but it could be. That's a good guess. Yeah? Ionic imbalance due to various toxins. So I like ions, toxins are definitely part of it. So basically, cytotoxic means as the cells die or undergo necrosis, they release their intracellular contents. And these are things like calcium and sodium and chloride and glucose. So all of the intracellular contents leak out, and that causes fluid to come into the area through an osmotic gradient. So those two types, the fluid that's coming through leaky vessels or the fluid that's drawn into the brain by toxins or ions that are around in the area, usually as the result of necrosis. And what you see over here, this is the area that has edema. So it's kind of hard to describe, to see in a lot of detail, but, you can see over here, see the distinction between the gray matter and the white matter is very clear. I can kind of draw that outline very easily. In an area of edema, you lose that distinction, the gray-white matter border. So I can trace it along here. But you can see it's not quite as distinct. And then on the inside, you can see that the white matter area, all of this stuff, is much bigger volume-wise than the gray matter along the outside. So that this area is looking like it's kind of being squished. That's a volume effect. The gyri and sulci are becoming blurred. So you don't have these nice gyri here and sulci here. You can see that they're kind of looking like they're squished over here. So it's really volume changes. And then the other thing that a pathologist will look for to see if there's signs of edema, especially subtle signs, is midline shift. Because sometimes you can't see, if it's a small area, you might not necessarily see that blurring, or you might not see the flattening of the gyri. But you can see here, there's been some midline shift. And as it shifts over, the corpus callosum is a little bit stretched on this side compared to this side. This is the cerebral aqueduct is actually pushed over to the side rather than staying straight down the midline. And then, as you'll see with many neurologic injuries in the brain, the outcome is widely variable. One thing is that it causes an increased intracranial pressure, which leads to headaches. It really depends on the area that's undergoing edema, but the cells in that area will start to lose their ability to function. And so you'll get functional deficits related to the area that's being disturbed. Here, This is temporal cortex. So this area of temporal cortex is swollen. Temporal cortex is involved in memory processing, emotional processing, facial recognition. So you may see people who have a little bit of a hard time recognizing somebody that they know, that they remember from a while, but they can't quite put it together. Or they might just have some strange emotional affect. So it really, the functional deficits depend on the brain region that is affected. And then, of course, if the edema or if the intracranial pressure increases too much, you'll start to get global dysfunction, which can lead to coma and ultimately death. Hydrocephalus is very similar. This is another volume disorder. It's caused by increased cerebral spinal fluid within the lateral ventricles. So right here, this is the lateral ventricles, but they're hugely enlarged. They're greatly enlarged. And you see these widespread volume effects because of that. So see the flattening of the gyri along the outside? All along here, you can barely see any distinction between the gray and the white matter. These ventricles, again, are dramatically enlarged. So what do you think is the main cause of hydrocephalus? Why would you ever get so much fluid inside the ventricles? Yes? Yep. So the number one cause is an obstruction of the CSF flow. And this could be anywhere. So the CSF is generated in the lateral ventricles. If you have a tumor in the midbrain that pushes on that cerebral aqueduct, which drains the lateral ventricles, that fluid is going to build up there. If you have one lower in the brain in the fourth ventricle, you could get some blockage as well. So another big cause of obstruction might be herniation. So if you have edema with midline shift, as it shifts within a closed space, that can cause part of the brain tissue to herniate or move into the aqueduct or into the ventricles and block the flow of the CSF. So anything that's obstructing that normal CSF flow can cause hydrocephalus. A very rare cause of hydrocephalus would be too much CSF production. But it's quite rare. It'd be like a tumor of the choroid plexus. And usually your body can accommodate increases in CSF production by increasing the flow and reabsorption of that fluid. So by far the number one cause is obstruction. We already talked about the morphology. Outcome is pretty much all the things we said with increased intracranial pressure. Now with hydrocephalus, it's more global, so you don't tend to have as many discrete functional deficits. It really becomes an overall inability to think clearly, inability to process information, eventually leading to coma and ultimately death, if not treated. Yes?
Would this patient, if alive, even be conscious?
Probably not at this stage. Yeah. This is a pretty severe hydrocephalus. And this is just another picture. They did a craniotomy, and which is basically cutting the skull and lifting the skull off to relieve the pressure. This was not in a living person. This was in a cadaver. But the main thing to observe, is that when you look at it grossly, you can see blunting of the sulci and gyri, and there would be very little subdural space because the brain has swollen into that subdural space. blocking those bridging veins, further making problems inside the skull. Okay, but I wanted to get into cerebrovascular disease in our last few minutes. Here's another one of those body worlds images where they injected the cerebral vessels and looked at the vasculature of the brain. So there's a ton of vasculature of the brain. Why? Why do you need so many vessels in the brain? Yes. Oxygen, nutrients. The brain is one of the biggest consumers of energy in the body. So all of that work, when we were talking about generating action potentials, summating dendritic information, requires a lot of energy. These are all ATP generated or ATP requiring processes, generating neurotransmitters, reuptaking those neurotransmitters for recycle, packaging them into vesicles. That calcium-mediated synaptic, forget what the word is, my brain's not working, where the synapses fuse, synaptic fusion, thank you. When the synapses or the synaptic vesicles fuse, all of those things take a lot of energy. So neurons are really energy intensive. And throughout the body, the density of capillaries directly correlates with the metabolic needs of the tissue. So metabolic needs of the brain are very high. So of course that makes the brain very vulnerable to cerebrovascular disease, just like with the heart. So we have hypoxia. This is really global hypoxia. And this could be caused by hypotension, has anybody had orthostatic hypotension where you sit down or you're laying down and then you suddenly stand up and you black out? Most of us have experienced that at some time. Some people have it more than others. So if you tend towards low blood pressure, or you haven't drank enough fluid, which can cause your blood pressure to be low, when you stand up, you temporarily don't have enough pressure to get blood into the brain because it requires that pump has to get all the way up there. So if your blood pressure drops too low, you can't get it. And if your systolic is below 50, then your brain is not getting enough oxygen. So temporarily that can happen when you stand up. Usually it's only a few seconds, you black out, you come right back. It's not enough to cause damage to the neurons, but you can see from that blacking out what would happen in somebody who has like septic shock, where they just don't have enough blood pressure to get oxygen up to the brain. So there's a global loss of function with hypoxia. Other things that can cause this are things like, these hikers from down in the valley who come up and do Humphreys, they get up to the top and they're suddenly very woozy. And it's because there's not enough oxygen in the air. They don't have enough hemoglobin. We all do, because we live up at 7,000 feet, but they don't have enough hemoglobin to carry enough oxygen in their blood to meet the needs of the brain when you're hiking up Humphreys. So anything that causes you not to carry enough oxygen in the blood. So that's a relative anemia. Anybody who has anemia may have hypotension may have hypoxia to the brain without hypotension necessarily. And then we have infarction. So this is more discrete. So this is a blockage of a vessel that feeds the brain. And you have quite a few redundant systems in the brain. So when you block a vessel, you're going to lose blood flow to one region of the brain, but you'll never lose blood flow to the whole brain. And then the last type of cerebrovascular injury is hemorrhagic disease. So this can usually can be caused by hypertension. And I'm talking severe hypertension. This is where your systolic blood pressure is well over 200, 250 up to 300. That's hypertensive emergency. And just that increased pressure can cause vessels in your brain to rupture and cause an intracranial bleed. Any kind of aneurysm. An aneurysm is just a weakening of one of your blood vessels so that blood pools in that area. And those weakened walls, that pooling blood, is more delicate and prone to rupture. So an aneurysm can rupture, and that can cause bleeding in the brain. And then also an infarction can cause bleeding as well. So there's a lot of reasons you might get intracranial hemorrhage. So let's look at global hypoxia and ischemia first. And I already mentioned the causes. Hypotension, hypoxia. So somebody with a respiratory disease, right? They might have hypoxia because of impaired gas exchange, and that can lead to global hypoxia of the brain. I should say hypoxemia, so that you know that I'm talking about hypoxia of the blood leads to hypoxia of the brain. So grossly, this will just look like edema. So you'll just see swelling throughout the brain, rather than in a discrete region. So do you think you'd see a midline shift? No, because it's all throughout the brain. So midline shift is a phenomenon with focal ischemia or focal edema. If we're talking global hypoxia, all of the brain will be equally affected, and so you'll get general swelling throughout the brain, no midline shift. But you will see the blunting of the gyri. Microscopically, you read about this, you'll see these red neurons. So when neurons start to, when they don't get enough oxygen, they're the first cells that are affected because their metabolic needs are so high. And so you can see on a slide, a lot of the cells, these purple are nuclei of support cells, the neuroglia, and they're still relatively fine. It's the neurons that start to change first. And so they become eosinophilic, they become pycnotic. Eosinophilic means they get that pink or reddish color. And that's their cytoplasm becoming more vasogenic, it has the leaky membranes causing more calcium to come into the cell, so the cells actually start to swell up. Takes up more of the eosinophilic dye. They also become swollen and pycnotic. What does pycnotic mean again? Means the nucleus shrivels up and disappears. So you can see in this red neuron here, there is no nucleus to be seen. Outcomes, again, as we saw with edema, you're going to have increased intracranial pressure, which can lead to loss of consciousness, and ultimately death. All right. So I apologize about Thursday. We will pick up again on Tuesday of next week, and then your last class and last mini exam is on next Thursday.